go ahead and do this second part. We will focus on tuberculosis treatment and side effects, as well as interactions with antiretroviral therapy in the setting of HIV co-infection. So these are the objectives. We will go over treatment options for tuberculosis infection as well as tuberculosis disease. This first part is focused on tuberculosis disease in HIV patients. So in general, the treatment is the same as for non-HIV infected patients. And we have the usual 4 drugs, and you are very familiar with them. We have rifampin, isoniazid, INH, pyrazinamide, as well as ethambutol. So those are the 4 drugs that we will usually start in somebody who has tuberculosis, unless we're thinking about multi-drug resistant tuberculosis or resistance to rifampin, INH resistance, etc. And there's usually an intensive phase, and this is 2 months, right? The first 2 months where you use the 4 drugs. And this is the known RIPE regimen, is on a daily basis, and it's given by direct observed therapy, as well as the continuation phase, right? So you work very in close contact with your local health department, because they are the ones who will do the DOT. And in terms of how many days, it's usually the 5 days, Monday to Friday, are really DOT. And most of the times we'll give the option to the patient. We will suggest to the patient to take the additional pills on Saturdays and Sundays. So the things to remember is that ethambutol can be stopped if the isolate is known to be rifampin as well as isoniazid sensitive. And then when we're dealing with an isolate that is rifampin resistant, we will think about adding a quinolone, either moxifloxacin or levofloxacin, and we may also consider adding an aminoglycoside. Now, that's the 2 months of intensive phase. Then following that, we have a continuation phase that is usually an additional 4 months. It may be longer than that, and we will go through that. But we can usually go down to just 2 medications, which are rifampin and isoniazid. And you can see there how important these 2 medications are in anti-tuberculosis treatment regimen. So rifampin and INH will stay for another usually 4 months. And these are, again, given in general. Most of the times we'll suggest keeping the regimen daily. There is data to support doing it thrice or 3 times a week, but no lesser than that for an HIV patient. We definitely do not get to twice a week. In general, I will suggest doing the daily regimen. And then the other thing to consider is that when you have a patient on whom you have a high suspicion for tuberculosis, and we were talking about this the other day, that the smears and even the PCR may be negative, but if your clinical suspicion is high, you may consider starting empiric TB treatment after collecting the necessary specimens. So you don't necessarily have to wait for the cultures to start growing, meaning 3-4 weeks later, to start empiric regimen if your clinical suspicion is high. And this is just because diagnosing tuberculosis in somebody who has HIV sometimes becomes so challenging and so difficult that it may not be a good idea to wait another month or so while you're waiting for the cultures. Now, in terms of the duration of the treatment, is for pulmonary TB, it's usually 6 months. We can think about doing a longer course, 9 months, if the cultures remain positive at 2 months, or if we're dealing with a strain that is PCA, pyrazinamide resistant. Most of the times, if we're dealing with INH, isoniazid, monoresistance, we will also prolong the regimen to 9 months. Although there is some data for appropriate therapy and decent outcomes with just 6 months, but most people will go up to 9 months. and we may need longer courses, even longer than 9 months for strains that are rifampin resistant. Now, when we're dealing with a patient who has a CNS tuberculosis meningitis, we usually talk about 9 to 12 months. And if it's a bone and joint tuberculosis, we go up to 9 months. And the role of the steroids is really for tuberculosis in the CNS, as well as TB or tuberculosis pericarditis. And feel free to interrupt at any time if you have any questions. Moving forward, so what about treatment of HIV in tuberculosis disease? So if the patient has been on antiretroviral therapy, you just continue the HIV meds, right? However, now that you're going to be starting the patient on tuberculosis treatment, you need to take a look at the HIV regimen, and you may need to make some changes depending on potentially severe interactions or major interactions with tuberculosis medications. Now, if the patient has not been on antiretroviral therapy, the question is, when do you start the HIV medications? Do you start the HIV medications as soon as you start the TB medications? And usually the recommendation, this is from the most recent guidelines, is if the patient's CD4 count is less than 50, you should be starting HIV medications within the first 2 weeks. And if the CD4 count is above 50, you should be starting antiretroviral therapy, HIV meds, by week 8 to 12. And this is supported by a number of very well designed trials which were published back-to-back a few years ago. These have been trials that included patients from pretty much everywhere around the globe if you take the three of them together. So these are recommendations that come from very good data. Some experts will also recommend, and based also on sub-analysis from these studies, they recommend starting HIV medications 2 to 4 weeks if the CD4 count is above 50, but we're dealing with a severe case of tuberculosis disease. And really the main unresolved issue in terms of when to start HIV meds is in patients who have tuberculosis meningitis. There was this Vietnam study that showed really no survival benefit when HIV medications were started early. And there were actually more severe adverse effects. In terms of drug interaction considerations, this is very important because nowadays, with all the bad press and all the negative side effects that a tripla has, we're kind of leaning towards not using a tripla unless we really have to. Now, in the HIV tuberculosis co-infection setting, it really has a role, because there are a number of trials that show really good outcomes when you have a patient on a tripla for HIV and you are treating that person for tuberculosis disease as well. Now, the most recent guidelines, and there was a lot of debate about this, because there was some data showing maybe a decrease or a decrease efficacy of efavirenz when it was used in combination with tuberculosis medications, and there was a prior recommendation of increasing the dose from 600 to 800, but really the most recent guidelines suggest that there is no need to adjust efavirenz dose based on clinical experience and clinical data that we have up to date. Now, remember that rifampin decreases the levels of almost all the HIV medications that we have. So nevirapine is not recommended unless really needed. We don't really deal with this much. It's a drug that is, although it's used in other parts of the world, the use of, when you're going to use a PI, you should not use rifampin. You should use rifabutin containing antiretroviral therapy, and it's usually an adjusted dose of rifabutin, where you're usually talking about 100 milligrams daily, and the dose of the PI does not need to be changed. And when we're using raltegravir, although you have to be cautious with these because there is no great data, the recommendation is that if you're going to use it in combination with a rifampin-containing regimen, you should double the dose. So instead of the usual 400 milligrams twice a day, you should do 800 milligrams twice a day. The one thing to remember is if your patient is on Stribild, you should think about switching to a different HIV medication, just because rifampin will decrease the levels of not only elbigravir but also cobicistat. So there is a significant interaction there. So you shouldn't really use Stribild with rifampin. Well, dolutegravir is one of the new ones, right? And the package insert recommends based on data data from PK and as well as clinical data. It's limited clinical data that you should also increase the dose, double the dose from 50 milligrams daily to 50 milligrams twice a day if you're using dolutegravir with rifampin. Now, this is a table just to show you that side effects are common, and the interesting thing is that there are side effects that are shared by the HIV medications that you're using and the anti-tuberculosis medications that the patient will be on when we have HIV and TB co-infection. So it's sometimes very hard to tell if the side effect that the patient is experiencing is from the TB meds or the HIV meds. And that's why we may not start them at the same time. As we were talking, the CD4 is less than 50, you have about a couple of weeks of a window period just to see how the patient will tolerate initially the TB meds, and then you can think about adding the HIV medications. Now, this is the only case that I have, and we'll go through this briefly. But let's talk about this one. So this is somebody who was diagnosed with HIV, low CD4 count at intake, 113, and at the same time he's diagnosed with pulmonary and lymphatic tuberculosis. And you can see there's not a lot in this right upper lobe, but you can see that there is an enlarged mediastinum, similar to the patient that we talked about the last time, with some lymph nodes over there. And so this person is started on tuberculosis medications, and 3 weeks later is started on HIV medications. And after 4 weeks of being on HIV meds, you see that the chest X-ray is much worse. Now you have an enlarged heart, you have a much more enlarged mediastinum, and there is something going on also which seems to be worsening in the right upper lobe. So what do you think about this? Do you think that this is progression of TB disease due to resistance? Do you think that this is progression of TB disease due to malabsorption or poor compliance with medications? Do you think that this is a different infection, an immune reconstitution syndrome, all of them, none of them? What do you think?
Okay, I'm unmuting the lines for people to answer. Might mute that one back. Okay, so someone want to answer?
My first guess would be D, but it could be all of them.
Yes. And this is a case of immune reconstitution syndrome, but you're right. I mean, this could be all of them. And remember that immune reconstitution syndrome is a diagnosis of exclusion. So you really need to work this patient up and make sure that we're not dealing with either a resistant strain or it's not uncommon for especially HIV/AIDS patients to have malabsorption. There is a little bit of HIV enteropathy, and low levels of TB medications have been associated with HIV/AIDS as well. So it could be a different opportunistic infection. So you have to be very careful with making a diagnosis of immune reconstitution syndrome. At the end, this is what the patient had. But yeah, remember that it can present, immune reconstitution syndrome can present as a worsening. You may think about a worsening case of tuberculosis, but it may just be that the CD4 count of the patient, the immune system of the patient is coming back, and there is an inflammatory, stronger inflammatory response, and the patient becomes more symptomatic. So briefly, there are two types of IRIS, immune reconstitution inflammatory syndrome. The paradoxical IRIS is that really the patient is, the tuberculosis is getting under control, but the patient is having more symptoms. But what we just saw in this case. Now, a masking tuberculosis IRIS is when the patient has not been diagnosed with tuberculosis. And you make the diagnosis after starting HIV medications, just because the patient becomes more symptomatic at that time with the CD4 count recovery. And if we talk about which one is more common, paradoxical TB IRIS is definitely more common, and it can happen at any time, but it's usually within 2 to 4 weeks of HIV therapy initiation. And the symptoms can look like worsening of tuberculosis, fever, enlarging lymph nodes, new or worsening infiltrates and effusions. And it can be a life-threatening condition, especially when we're dealing with CNS tuberculosis, and the symptoms can last for a number of months. There are risk factors that you can see over there, especially the ones who start with very low CD4 count will be the ones at risk, the ones who started with extrapulmonary tuberculosis. And now that we're calling for a shorter intervals between TB medication and HIV medication, we're seeing more tuberculosis IRIS, although it's usually mild, and we can just treat with, we can just treat the symptoms, and we just go ahead and continue the TB as well as the HIV medications. And the diagnosis, remember, is a diagnosis of exclusion, and maybe very challenging. You really need to rule out other concomitant infections and worsening of tuberculosis to call these IRIS. The treatment, remember, do not stop antiretroviral therapy. We may sometimes do that, especially if we're dealing with CNS, but in general, you don't need to start, you don't need to stop HIV medications, providing symptomatic relief. There is a role for steroids in the more severe cases, and NSAIDs have been tried as well. Now, let's talk briefly about treatment of LTBI, which is probably one of the conditions that you will be treating the most. The one thing to remember is that HIV-infected persons who test positive for latent TB and do not have evidence of tuberculosis disease should receive latent TB infection treatment. So it's really, if the patient has a positive quantiferon or a positive TST or a positive TB spot test, and the patient has HIV, that patient will definitely benefit from getting latent TB treatment. And when HIV-infected persons become close contacts of patients who are diagnosed with TB, regardless of the TST or IGRA results, we will think about providing LTBI treatment or prophylaxis, right? And the preferred LTBI regimens are shown over here. The one that has the best data is INH, and we usually give these for 9 months. And there is also an alternative, as you can see over there. There's a twice-a-week regimen that I don't have much experience with this. It has to be by DOT, but the best data really comes from daily INH. And there are alternative regimens, as you can see over there, the rifamycins for 4 months, the 120 doses you're probably familiar with, rifampin 60 milligrams daily, or rifabutine. And the rifabutine, remember, that has to be dose adjusted based on the HIV medications that the patient is on, and it's also for 4 months. And those who are exposed to MDR TB cases, then you need to talk to an expert because there may not be options, or there may be an unusual option. Quinolones have been tried. Sometimes we'll just monitor depending on what kind of MDR TB case the patient was exposed to. And then the other thing that is important, remember we were talking about this the last time. This is a syndemic. The HIV has an effect on tuberculosis, and tuberculosis has an effect on HIV. So whenever somebody is diagnosed with LTBI, you also have to think about treating the HIV infection. And what about these combos? Some of you may be familiar with this new rifampicin and INH weekly, which is given 12 in a 12-week and a 3-month period, and it has been shown to be as effective as the 9 months of INH in basically a non-HIV population. Currently, this regimen is not recommended for HIV-infected persons receiving antiretroviral therapy because of the potentially significant drug interactions between rifampicin and some of the HIV medications. Although there is a recent study that is being published in Clinical Infectious Diseases that talks about PK results of, for example, a 5 years containing regimen and rifampicin containing regimens, and the results are pretty good. So these may be changing in the future, but for now, the most current guidelines do not recommend using this combo. This is just to show you what in mainly non-HIV population the study showed. It's pretty equivalent to using 9 months. These 12-week once weekly INH and rifampicin is as effective as doing the 9 months of INH, and it has less rates of hepatotoxicity, and obviously it has high rates of treatment completion. Now this has to be, and this is currently approved for non-HIV patients to be given by direct observed therapy. So that's another thing to remember. There was a recent abstract that was presented at CROI last year that talked about the experience with this regimen in HIV-infected persons who are not on antiretroviral therapy. So let's say those who have not started, are newly diagnosed, have not started HIV medications yet, and you do a quantiferon, right? And it showed, it had pretty good results. There were some limitations in this study, talking about the small sample size and the design that was an open label study, and the fact that the patients were unable to receive HIV medications for the first 90 days while they were receiving treatment for LTBI. But this is something that you may be seeing in the future. Guidelines may be changing a little bit in the next few years, depending on what studies show with this regimen. And just to give you a sense of some other regimens that are being tried, this is for latent tuberculosis infection. This is a regimen that is being particularly studied in persons who have HIV, which is a ultra short regimen of daily rifampicin and INH for a month, and we will see what the result versus the usual the traditional INH for 9 months. We'll see what that study shows, and then there are a number of other studies that may not include HIV patients. So in general, the overall conclusions from these 2 sessions. Always think about tuberculosis. It's rare, but it's still there. All HIV-infected persons diagnosed with LTBI should be treated for LTBI, and recognize the proper timing, potential drug interactions, and risk of immune reconstitution syndrome when starting HIV medications in persons who are on tuberculosis treatment.